This is a topic that we usually put at the end of the day because people can leave without having to hear it and not waste their time kind of thing, because this is a doctor bashing section of papers. We did a course in Whistler at the beginning of the year, and at the same time that we were there, the Super Bowl was on. And the Americans had, we were watching Canadian television, so they weren't broadcasting these really super commercials that everybody watches the Super Bowl for, to see these commercials. They had their own Canadian commercials on there. Yeah, and so you didn't get to see them, right? But one of the things I saw repetitively in the Super Bowl was a commercial basically that said, not all bugs need drugs. Not all bugs need drugs. You know about that thing, that big...
It might be a BC Health thing.
Okay, it was in British Columbia.
Healthcare is it's a provincial...
Okay, so they had this, over and over again, they had this commercial, not all bugs need drugs, sponsored by the family physicians and the pharmaceutical, the pharmacist, not the pharmaceutical industry, the pharmacist basically saying not all bugs need drugs, which was really terrific. It was a really well done commercial, basically trying to get the word out to parents that you shouldn't be expecting antibiotics every time you go to run to the doctor for a runny nose, et cetera, et cetera. And I thought, geez, why don't we do something in this country? The internet and TV is so popular and so powerful.
Texas does that.
Texas has an, and we could just take that whole commercial. It was done so well. Just put it down here, borrowed it from the Canadians. Thanks very much. So that in fact people get the sense that you don't want to be viewed as an outlier. You don't want to be viewed as some kind of wacko doctor kind of thing when everybody else is giving antibiotics and you're not. They say, what kind of doctor is this kind of thing here? So if we can all lock arms and say, yeah, this is the way we do it now kind of thing, and acknowledge that we are changing our practice, it would certainly help us a lot, I think. American Academy of Pediatrics has come out with, they've got posters that you can put in your emergency departments and little handouts about, resistance, and all of these things should help make you not look like a wacko doctor because you're not giving out antibiotics like patients seem to expect. One of the other problems with giving out antibiotics for these viral illnesses is that it drives people to go to the doctor for things that they ought not be there for. You all see people, the kid's got a cold, got a runny nose. It's a new mother, and this mother knows absolutely nothing about kids except how to get pregnant. And they bring these children in, and it's like you need a license to have a kid, to learn that this is just a cold. You don't need to come. It's got a little snuffy nose. Here's what you got to do. But they've been waiting 2 hours to be seen out there. You're going to bring him in there and say, well, it's a cold, Mom, and it'll go away by itself. And what kind of doctor are you, man? I've been waiting 2 hours here. You got to reward my behavior. Okay, just in case, we're going to prevent Otitis Media from developing. Here's some amoxicillin kind of thing. Oh, that's better, doctor. Thank you very much. So, how many millions of visits do doctors see of kids who really ought not have ever been there in the first place? And now you are compelled to do something because you're going to charge them. And in the ER, we're going to charge them a lot for nothing. And now they've taken away all of the stuff that it was given over the counter. All that, doctor-preferred Dimetap, it's gone. None of that stuff ever worked, but they were able to provide, buy it at the drugstore. Well, now in the States, they took all that crap off you can't give it to a kid under 2. They took it off the shelf, changed the label and kind of thing, and they say kids over 2, doesn't work in them either, but the issue was disproportionate side effects, etc. So all of this doctor-preferred Dimetap, which was a commercial in the United States over and over again, that stuff is crap. Did you see the paper? It was a New England Journal about Robitussin and honey, and honey basically worked better than Robitussin kind of thing. What next? Robitussin mixed with honey, I think it will probably be it. So there's these issues of driving visits with expectations that we have to deal with. There's an ethical and trust issue. They would say, well, the doctor wouldn't give me something that wouldn't be good for me. I trust the doctor. He's my doctor. She's my doctor kind of thing. So there's an implication that what you're doing is the right thing for them when you know damn well it probably isn't. And then there's this issue about costs. What are the costs? Well, the costs are dollars. Augmentin still costs a lot of money. The cost is in resistance, which it's interesting about how people feel about resistance. Well, I'll show you some papers that basically say, I think resistance is really important for everybody else except me. I'm with the antibiotic. You know, on an individual level, you don't really care. It's just, you know, it's like global warming. I know it when I see it, but I'm still driving my SUV. Thank you very much. And then there's the side effects issue. We'll talk about a paper that talks about how many kids get diarrhea from and other kinds of side effects from antibiotics. The first cluster of papers try to look at what we're doing, and they're using a variety of databases. The one that they use most commonly is, which is called the National Ambulatory Medical Care Survey. These are a series of private and group practices around the United States that have been statistically chosen so that when they take all of this data from these practices, it represents and can be extrapolated to the universe. They're physically located in different spots in the country, those kinds of things, so they can say this sample, when extrapolated, does represent how many visits we have or this, that, and what doctors are doing. There's another version of that, which is called the National Hospital Medical Care Survey. The National Hospital Medical Care Survey is divided into two portions. One which focuses just on the emergency department, and then there's another one that focuses on hospital clinics. The one that is focused on the emergency department is kind of interesting because, you know, whenever they say, well, there's so many visits for something in the United States, well, how do they know that? What they do is there's 550 emergency departments around the country that have been, again, statistically validated that these are, when we take these 550 emergency departments, what happens in them is a valid sample to say this is what's happening in the United States. Each of those 550 emergency departments takes 100 patient visits, and the medical records department people at those hospitals fill out a separate piece of paper that they have volunteered to do on 100 visits, looking at what was the ICD-9, what was the CPT codes, what medications were given out, what was the ethnicity of the person, how long were they in the department, this, that, and the other thing, looking at that, and basically from 550 hospitals, 100 visits. What is 100 times 550? It's 55,000 visits. From that, they extrapolate what happens in the emergency department throughout the United States. But in fact, in the United States, they see number of ER visits is like 110 million. So the sample size is 55,000, representing 110 million visits. Well, you can say, is that a decent sample? Well, maybe it is, but they say it is, but it's really a very small number of patients that they look at. Well, anyway, those are the genesis of some of these papers, and let me just summarize them. They basically say that we are, for all of these virally related illnesses, like bronchitis, sinusitis, not so much otitis, colds, and those kinds of things, that we are basically giving out less antibiotics than we used to by a little bit. Now, when we talk about how much we're giving out, I'll get you some papers. But yes, we are getting a little bit better. Over time, maybe 5–10% decrease in the use of antibiotics. Yeah, I also say, yes, we are using less antibiotics, but what antibiotics are we using? We're swapping out. If you take a look at paper number 3, this paper says, yes, there was a 43% decrease in the use of amoxicillin and ampicillin, and a 28% decrease in the use of cephalosporins, and a 76% decrease in erythromycin. Wow, 76% decrease in erythromycin. Why? Because there's a 388% increase in azithromycin. The Z-Pak, basically, there was an 80% increase in the use of quinolones for respiratory illnesses and a 69% increase in the use of augmentin. So the idea is we're swapping out the narrow range stuff, the inexpensive stuff, for the broader spectrum, more expensive stuff. And the Z-Pak is at the top of the list. Whoever came up with, let's make a Z-Pak of this kind of thing, should have gotten a really big bonus kind of thing. And in fact, some of these illnesses, like, they now have this thing where you take this like one dose of azithromycin. Does it last like 6 months or something like that? It will sterilize you. And now you can just lick the tablet kind of thing. You know, that's all you need kind of thing. So that is the trend. Yes, a little bit decrease. But let's look more specifically. It's what's happening in emergency departments. Now, Richard Gonzalez did number 4. This guy is one of these infectious disease gurus who focuses on emergency medicine. So what he did in this paper, this data is fairly recent, was published in, the data is from hospital surveys. They look at 14 emergency departments, 2,300 patients, seen over about a 3-month period ending in February of 2004. So relatively recent data. Looked at the prescription of antibiotics for antibiotic non-responsive disorders. primarily URIs and bronchitis. It's interesting, there is a ICD-9 for URI, and there's also an ICD-9 for colds, which are, last I heard, they were the same. But they do have two separate. So whenever you look at this data, you'll see antibiotics for URIs, antibiotics for colds, antibiotics for bronchitis. What is this story? That's because there are two separate ICD-9s. So if a doctor puts down URI, they're going to put that down ICD-9. Doctor puts down a cold, they're going to put down that one. But in any case, these are people who have antibiotic unresponsive illnesses, URIs and bronchitis we're talking about. These visits accounted for 62% of the respiratory infections seen in these emergency departments. And who got antibiotics? 72% with the diagnosis of bronchitis got antibiotics. We believe that if you say bronchitis, that you could convert a cold, which doesn't require antibiotics, to a disease that does require it, just by changing the name. You know, nobody's going to fault you for giving antibiotics for bronchitis, but you would be a jerk to give them for, you know, a cold. What kind of doctor are you? You know antibiotics don't work for colds. Of course, we're going to make it bronchitis. So one of the problems in this is that the doctors are going to be semantically saying, okay, I'm going to give you antibiotics, but I'm going to put down a socially acceptable diagnosis, which will allow me to do that. So that's there. 38% with a diagnosis of URI. These doctors, I admire these doctors. They had the courage to say, you got a cold, and I'm still giving you antibiotics. You know, I'm not going to lie. I'm not going to fake it kind of thing. You got a cold, and here's your antibiotics kind of thing. I admire those doctors. One of the things that was fascinating, now remember, this is 14 hospitals. And these are, they're looking at disorders that are non-responsive to antibiotics. In one hospital, 42% of the patients came in who had one of these diagnoses got antibiotics, 42%. And in the hospital at the other extreme, 89% of the people who had the same diagnosis got antibiotics, which means we seem to watch what our colleagues do, and we are kind of monkey see, monkey do. Oh, Fred gives that stuff out too, you know, okay, I'll give it. You feel much more comfortable acting like your colleagues when you see how your colleagues behave. So this is only 14 hospitals, going from 42% antibiotics in this one, which is fairly conservative, certainly lower than the national average, to 89%, which where these doctors believe that everybody should go out on an antibiotic no matter what's wrong with you. The last of these papers is, well, let's skip that one. What are the consequences of heavy use of antibiotics in primary viral illnesses? We want to discourage, we want to have some reasons for mom not to feel that she wants antibiotics for little Mary here. One of the reasons is, you know, there isn't, if we give it too many antibiotics, it make it asthma. Look at paper number 6. So here we go. We have 13,000 kids born in 1995 that followed them for 7 years. And how many of those kids were diagnosed at the end of the 7 years with asthma? 6%. They went back and looked at the records and said, in the first year of life, if you got more than 4 episodes of antibiotics, you were almost 1.5 times more likely to be diagnosed as asthma. And if you got antibiotics, even if it wasn't for respiratory illnesses, like you had a cellulitis or you had some other reason or a urine infection or something like that, that also increased your risk of getting asthma. Of course, we're not talking about causality here. We're talking about an association. You can't say that. Maybe kids who get 4 respiratory infections a year are already prone to asthma kind of thing. Maybe the antibiotic was the canary in the mine, but the real problem was that this kid's getting respiratory infections over and over. Maybe they have a propensity to develop this disorder. But don't tell them that. You say, you know, there's an association between too many antibiotics when you're a little kid and asthma. That's all. Don't have them critically read the study. You need some ammo here. You need ammo. Go ahead. That's exactly what I was going to say. So that's one element of the ammo. We don't want Johnny to get asthma here. We want to cut down on these antibiotics here. You can tell them about the study, and you can give them a copy of the abstract there, kind of thing. What about diarrhea? It's one of my favorite papers. Is 650 kids who got antibiotics for God knows what reasons. The average mean age was 34 months, so 3-year-old kids got antibiotics. How many of them got diarrhea? They had a good definition for diarrhea in this paper. It wasn't kind of like a little make-believe diarrhea. It was real diarrhea. 11% got diarrhea. How long were these kids on antibiotics? 8.6 days. That's an eternity to be on antibiotics. When we treat bladder infections for 3 days, we treat these viral infections for 9 days, kind of thing. It's like sinusitis. People say, oh, you can't be treating sinusitis for a week. It takes 3 weeks to get. Well, if it takes 3 weeks for antibiotics to treat sinusitis, is there another explanation that says antibiotics don't make your sinusitis better. Would you take that as an option? No. It needs to do 3 weeks of antibiotics. So they basically, when did they get their diarrhea? They got it 5 days into the treatment. It lasted, on average, 4 days, but the range was 2 to 17 days. The mother who had the kid for 17 days of diarrhea will never ask you for an antibiotic again in her life, kind of thing. And there was some increased risk about who was going to, hey, Ricky? I might need you to ask those people to knock it off, basically, or we're going to have to turn up our speakers here, kind of thing. I'm serious. You might have to go down and say, you have neighbors here. Where are we? Oh, yeah. Increased risk of diarrhea. Kids under two, the risk of getting diarrhea was almost twice as great, and if you were on Augmentin. Augmentin is the #1 diarrhea producer, kind of thing, which just happens to be the antibiotic recommended by the American Academy of Pediatrics and the AAFP for treating otitis media with kids with high fever. That's the one. And I said, well, where's the literature that says the height of the fever determines what antibiotic you could put on? What kind of literature is this? There was one paper published in 1402. I was not able to access this. I have access to all of the journals at University of Southern California Library. Couldn't find this one. One paper is cited as giving evidence why at a certain level of fever, it's appropriate for you to give Augmentin. What nuts that is. What nuts that is. And yet, and they also want you to give 90 milligrams per kilogram, which is clearly a diarrheal dose because 40 doesn't work. 40 is the normal dose, so here's your problem. You need to give more. It's always you need to give it longer or more because that will make the... How about 0 per kilogram, milligrams per kilogram in these cases? Now that's otitis media. The good part of those guidelines were doctors, you can, in equivocal cases, you don't need to give them antibiotics. You can watch and see, and it's a self-limiting disease anyway. At least 40% of them are viral. So in those cases, you have our permission not to give antibiotics, which is real cool, okay? We just did a paper, however. We did our tape yesterday here. This paper, National Trends in Emergency Department Antibiotic Prescribing for Children with Acute Otitis Media. So now we have permission not to give all of these kids otitis media. How are we doing? These came out in 2004, these recommendations about you can use observation. Basically, what are we doing here? Prescribing of antibiotics between 1996 and 2005 in emergency departments, it was 79% in 1996. It is now 86%. We're doing much better. We're approaching 100%, despite the fact that the American Academy of Pediatrics said we could treat some of these cases with observation, particularly when we weren't compelled to be sure that that was the diagnosis. And then lastly, there's this 8 and 9 talks about resistance. There's no question. Resistance, you sample the kid before the antibiotics, you sample them a week after the antibiotic. You have selected out now the resistant bugs. The sensitive ones are gone. Now you get the resistant ones. How long will they hang around? One paper says they will number 9 says they will hang around at least a half a year, 180 days. The incidence of resistance doubles when you give antibiotics, kind of thing. So it's fast. It happens with regularity. And especially in countries where they basically are able to control the use of antibiotics, primarily in the socialized medicine of, Denmark and the Scandinavian countries, they're able to show that their antibiotic resistance levels are much, much, much lower than they are in the United States because they don't give out antibiotics routinely for otitis media. It's the exceptional cases rather than the rule. We treat it 180 degrees differently than they do over there. How important is the use of antibiotics in most ENT infections and respiratory infections? We apparently think antibiotics work. We apparently think it because we're given them, or that we can, it's safer, or just in case, or there may be a prevention of where, you never know, mom, kind of thing. So we think that there's a safety net that they put underneath us. And I think that it's important to point out that the number needed to treat to get any efficacy from these things is really substantial. We are pain pill and antibiotic prescribers in emergency medicine. And we believe that every pill that we give will help that individual person. You have pain, we'll give you a pain pill, your pain's going to be less. You have an infection, a cellulitis, I'm going to give you an antibiotic, that's going to make this thing go away. You got some GI upset from nausea, something, I'm going to give you an anti-nauseant, and that's going to make your nausea go away. So every pill that we give out, we believe that person's going to get better with that pill, which is just the opposite from family physicians, because virtually every pill family physicians give out, nobody gets any benefit from it. Now, Jerry mentioned the diabetes pills yesterday. So we're going to give you diabetes pills to lower your sugar. That's really fine. And yes, it did lower your sugar. Did you have less heart attacks? No. Less strokes? No. Less neuropathy? No. Did you have anything less? No. But we gave you this pill. So the number needed to treat to get a benefit in the treatment of diabetes is over 1,000. I'll show you tomorrow. I should have brought it today. A paper. Same thing with cholesterol. They give out cholesterol pills, $3 a piece to take Lipitor. It's $1,000 a year. How many people are going to get benefit from taking a Lipitor pill to prevent a heart attack when they have high cholesterol? Oh, maybe 1 in 200 if you take it for 5 years. 5 years, 1 in 200 people, and maybe in that neighborhood, will have a heart attack prevented. If you told a patient, well, the likelihood of this pill helping you is about, well, you have to take it for 5 years, and you will be one out of 100 of you will get any benefit out of this. You think they take that pill? Nobody ever tells them about number needed to treat for diabetes pills, high blood pressure pills, lipid pills. It's this concept of number needed to treat. We believe when we give an antibiotic in the emergency department setting, we will help you. And that is not the case in these disorders. And I'll show you the literature on this is just absolutely compelling. But we have these also, even if that wasn't true, we have this issue of expectations. You know, that parents expect it. It's feeding the bears. We've been feeding the bears antibiotics for so long that when the bears come back, they expect to be fed antibiotics. And you can't say, well, we changed it last week. We're not feeding the bears anymore, you know, kind of thing. So there's this gradual necessity to have the people, doctors, and the patients buy into, well, maybe this isn't as good an idea as we once thought. You know, medicine evolves. We thought it was going to help in the past. We find out that there's more problems than we thought. What techniques can be used to reduce the use of antibiotics in most ENT and respiratory infections? How about making sure the diagnosis is correct? We love Otitis Media because there's no gold standard to make the diagnosis. We can say, I think this one is a little redder than that one. There you go, amoxicillin down, out, bam, kind of thing. One of the things, and we've done protracted lectures on Otitis Media, and this is not the place to do that, but the fact of the matter is that when you look at the number needed to treat to get any benefit, paper number 26 should have been put in here, but 26 says, you give antibiotics to a kid who has Otitis Media, what is the best thing that you can hope for? You will decrease the amount of pain that this kid has between days 2 and 7. Between days 2 and 7 of infection, those kids who get antibiotics, maybe they'll have less of that. How many kids need to be treated to get one kid to get that benefit? 8 kids need to be treated to get one kid to have less pain. We're not talking about, well, if you don't treat them, they'll have an earache for the rest of their lives, they'll have mastitis, they're going to go deaf. It's a self-limiting disease. So what you bought was one kid had a little less pain between days 2 and 7. 1 out of 8. So the other 7 got no benefit whatsoever. So I hope your kid is the lucky one, because most of them are not going to get any benefit whatever, except 11% of them are going to get diarrhea. And if you decided to use Augmentin in a kid under 2, the likelihood is 5 times greater than the average. Here's like an example, number 14, sinusitis. Everybody knows sinusitis needs to be treated with antibiotics. I have pain over my sinuses, I got this nasty drip kind of thing down there. Everybody knows you need to treat it. So here's 416 people. No, these people, then we're going to get the sinusitis. This is a purulent rhinorrhea, when the stuff coming out of the nose is really pretty interesting looking. 416 patients with it, but without sinusitis, compared amoxicillin to placebo for 10 days. Successful treatment, 35% with amoxicillin, 29% with placebo. Not statistically significantly different. So even if there was a marginal benefit, they were offset by the fact that 29% of the people on amoxicillin got diarrhea versus 19% of the control. So in that case, that was clearly a wash. What about, they go to a doctor, the kid's got a fever, and the doctor believes this is more than just a simple cold. This is a subset I think we need to give antibiotics to. That's the next paper, 15. 408 kids. 77% of them had probable viral infections on PCR testing. A good number of them had the flu. And 34% got antibiotics, and there was no effect on recovery whatsoever. Flu is this kind of, this atypical, you get fever, myalgia, and cough. At the time of the year, that's called the flu. Cold, you don't have much of it in the way of a fever. You have cough, runny nose, you can still go about your work. Flu, you feel just terrible, and so you have to stay home, basically the difference. People do not have the stomach flu. You hear people, I get the stomach flu. What are you, coughing out of your stomach here kind of thing, There is no such thing as a stomach flu, And don't, anyway. 16 says, okay, you want to use antibiotics, this kid's got a cold, you want to prevent the development of otitis media? Well, you just read the title 16. Augmentin is ineffective at preventing otitis media in children with colds. 17, antibiotic A versus antibiotic B, no difference in outcomes. Where's placebo? You have to be absolutely nuts to be a manufacturer of antibiotics and have your antibiotic compared with another antibiotic compared with placebo. You would never do that. They would fire you in an instant because all of the results of these studies are the same. Antibiotic A is always as good as antibiotic B. It is always the good because it doesn't matter. Because had you used antibiotic C, which is called placebo, you would have found that placebo is B equal A in these disorders. So the spin is always the same. You can take ours for only 3 days. Side effect profile was much better with ours. That's why you ought to take ours, because the outcomes were the same in the two cases. So you have to look at compliance, which may or may not frankly matter in these cases, and side effects, which probably do matter. Here's one that should never have gotten published. Number 19. It's funded by Glaxo. It's looking at augmentin or placebo for rhinosinusitis. Purulent nasal discharge, maxillary or frontal sinus pain. This is clinical diagnosis, same way you're going to make it. It hurts here, doc, I want to bend over, that kind of thing, and you got this stuff coming out of your nose that looks terrible. Comparing augmentin, which is at the top of the list of the drugs that should work here. Augmentin was compared with placebo in a manufacturer-sponsored study. These are reportable. They are so rare. No difference at 1 week or 2 weeks. Well, there's the problem. You didn't take it for 3 weeks. You needed to take it for a month. Or the dose was too small. That's all. Diarrhea, the odds ratio for diarrhea is 4 times higher because you are now taking the super diarrheal antibiotic augmentin at 1 week. What about a Cochrane review here? Cochrane review of antibiotics, 32 studies, 7,300 people, sinusitis. Penicillin was better than placebo. Amoxicillin wasn't. Well, that doesn't make any sense. Number needed to treat with penicillin to accelerate the resolution was 7. So you give penicillin to 7 people, 1 will get benefit, 1 will get benefit, most will not. So the best thing to do is to say, when we give these antibiotics, most people don't get any better from it. A very small percentage may. You may be in that lucky bunch, but more likely than not, you will not be. So that basically doesn't feel that, oh, geez, I didn't take my antibiotic today kind of thing, I'm going to die. They're all the same. They're all the same. Number 23, 10 days of cefuroxime was not superior to placebo in kids with URIs and sinusitis. It's over and over. There are literally hundreds of these papers basically saying the same kind of thing. So the people who get benefit is relatively small. Number needed to treat. This is the first time number needed to treat really comes into play in emergency medicine because when we give antibiotics out for these conditions, really doesn't help particularly. Even in the strep throat, there's good reasons to take antibiotics for strep throat. You'll probably decrease their symptoms by about a day. You'll decrease the communicability of the disorder kind of thing. But you're not getting a huge benefit by doing that. Rheumatic fever, there isn't really any rheumatic fever anymore kind of thing. So giving 10 days of penicillin, nobody's going to take it for 10 days kind of thing.